Hi class, in this lecture we will review the basic principles of antimicrobial therapy. There are several infectious disease lectures that will follow this initial lecture, and so this background will replace our normal pathophysiology for each of those. Most of the principles that I'm about to talk about will apply to all of the antibacterial drugs, antiviral drugs, antifungal drugs, even the HIV drugs. So antimicrobials are one of the most widely used groups of medications in the world. In fact, up to 190 million doses per day are used in hospitals just in the United States. That is an impressive number. They've been around a long time, actually since the 1930s, and there's no doubt that they've greatly reduced morbidity and mortality. And there are new drugs that are coming on the market even since I graduated from pharmacy school almost 15 years ago. But despite this, continued progress is needed. People still die of infections, and microbial resistance is a constant threat. The objectives are listed on the slide as well as in your Blackboard module. There are several vocabulary terms listed here. Please be familiar with all of these terms. The use of medications for treating infections is a little different than the use of medications for treating other conditions or diseases. Usually, when we give drugs to treat other conditions or diseases, what those drugs are doing is interacting with some receptor in the body. But that's not what we're doing when we're treating an infection with medications. The desired effects of the medication or the drug are on the organism, not the patient. So when we do see effects on the patient, we would not call those desirable. Usually, those effects from the drugs on the patient are what we would call adverse effects. So what makes the antibiotic drugs useful is their ability to be selectively toxic. And what that means is that they're able to kill or suppress antimicrobial pathogens without causing serious injury to the host in most cases. And like I said, that's the property that makes these drugs valuable. So how can this be? Well, the answer lies in differences in cellular chemistry of the host, or the patient, versus that of the organism. So these medications target biochemical processes in the microbe, but not in the human. And essentially, what we're targeting are things like the cell wall. So human cells don't have a cell wall, but many microbes do have a cell wall. We might be inhibiting enzymes that are only found in the bacteria. Or we could target protein synthesis process that is a little different from the process that would be seen in mammals versus the organism. And like I said, generally, if we do see adverse effects, in many cases, it's because whatever we're targeting in the organism, there may be some similar function in the human, not exactly the same, but somewhat similar. And so sometimes those drugs will be able to still target that somewhat similar process. For example, amphotericin B is targeting ergosterol, which is found in fungal cells. But when we see issues with amphotericin B use in a human, it's because of its effects on cholesterol, which is structurally similar to ergosterol. But in the end, for the most part, selective toxicity is very useful and what allows these medications to be useful at targeting those organisms without effects on the human. So let's talk about the classification of antimicrobials. Clearly, they can be grouped into different types, such as antibacterials, antivirals, antifungals. We're going to focus the majority of our discussions on those first three groups. But there are also drugs that target parasites like protozoans or helminthics, which are worms. We'll talk just in passing about those two classes, but really most of our time will be focused on the first three. They can also be classified by their spectrum of coverage. So when we think of spectrum of coverage, we usually think of either broad spectrum or narrow spectrum. Broad spectrum drugs are active against a wide variety of microbes. They're used for what we call empiric therapy. Empiric therapy is when we don't know the actual cause of an infection in a patient. We may have a very sick patient. We need to treat them very quickly. So, based on their signs and symptoms, we'll choose a drug that covers a variety of pathogens and start that therapy before we're able to get the results of laboratory tests and other types of tests that narrow that down to a specific a specific organism. So that would be the other end of the spectrum, right? Narrow spectrum. So with narrow spectrum, these drugs are active against only a few microbes, and this type of therapy is preferred whenever possible. We want to target our, specific bugs that we know are causing the infection, and we want to use a drug that is the best for that particular microbe that also doesn't cover several other microbes because that can lead to issues with resistance. And finally, we can categorize these drugs based on kind of how they work. Now, I'm not going to go into all the different mechanisms of action right now because we'll talk about the individual mechanism of action for each drug class. But a broad categorization of mechanism of action is whether the drug is considered bactericidal or bacteriostatic. Drugs that are bactericidal are directly lethal to the bacteria at clinically achievable concentrations in the blood. Bacteriostatic, on the other hand, these are drugs that slow bacterial growth, but they don't actually kill the bacteria. Rather, the host defenses kind of kick in and eliminate the bacteria. So it's kind of that combination of the drug slowing the growth and then the host defenses kind of picking up the slack. Now, we worry most about whether drugs are bactericidal or bacteriostatic when we are treating very, very serious infections, like meningitis, for example, or when we have a patient that's immunocompromised. And that's probably the main scenario that I would say this concern between cidal and static really becomes important. If you've got a patient whose host defenses aren't working properly because of their immunocompromised state, maybe they've got HIV or AIDS, maybe they have cancer and they're immunosuppressed because of chemotherapy, or there could be a number of other reasons why your patient could be immunosuppressed. So their host defenses are not working as well as a patient with intact host defenses. And so for those patients, it's more important, especially depending on the severity of the infection, that we choose drugs for them that will be directly lethal to the bacteria. All right, so let's talk about antimicrobial resistance. This is one of the most important things that we will discuss throughout the next several lectures related to antimicrobials. I'm sure all of you are well aware of the importance of minimizing antimicrobial resistance. I know throughout your curriculum, this is a thread that comes up again and again. So let's talk about why antimicrobials develop resistance and some things that we can do as healthcare professionals to prevent further resistance. So antimicrobial resistance, and when I say antimicrobial resistance, what I mean is pathogens that are resistant to specific antimicrobial agents. This resistance can either be innate or acquired. Innate is just, it's natural or inborn for that particular organism. That's not the one we really worry about. The one we worry about is acquired. And this means that the organism at one point in time was susceptible to a particular antibiotic or antimicrobial, but it no longer is. Or maybe now it's less susceptible. It doesn't work as well as it once did. In fact, there are many drugs that we will talk about throughout the next several lectures that are no longer able to be used for certain infections because over time the organism has developed resistance and in some cases the drugs just literally do not work anymore. This really does create a crisis situation in healthcare. Antimicrobial resistance is associated with extended hospitalization, significant mortality, significant morbidity, and excess mortality. So it's a real concern. Some of the organisms that we worry about, you may have heard of some of these. I'm not asking you to memorize these, but these are some of the ones that that really are high on the radar for having serious resistance patterns. Enterococcus, staphylococcus. I'm sure you've heard of Staph aureus, which is a type of staphylococcus. Enterobacter, Pseudomonas. Pseudomonas is a very concerning bug in the hospital setting, especially. Klebsiella, and even C. difficile. And again, I'm sure most of you have heard of C. difficile, causes pretty significant diarrhea that can be life-threatening. So you don't have to memorize those, but over your time as nurses, I'm sure that you're going to encounter patients that have these organisms, possibly resistant strains of these organisms. So a lot of people get confused with resistance. They think, it's the patient that's resistant, but it's not the patient, it's the microbe. So whatever microbe is infecting that patient, that's what is potentially resistant. So the question is, why, what is it, I guess, about antimicrobials what's that link between antimicrobials and resistance? Well, first I want to make sure you guys understand that antimicrobials themselves do not cause genetic changes that lead to resistance. That is just spontaneous mutations or conjugations that randomly occur over time as these organisms are dividing and multiplying. So it's not that the drug is actually causing these genetic changes. What's happening is that the drugs are simply making conditions favorable for overgrowth of microbes that have acquired those mechanisms for resistance. And so really you could say that antimicrobial use promotes the emergence of drug-resistant organisms, but doesn't specifically cause those genetic changes. So to kind of understand why that is, think about organisms and kind of the ecology in which they survive. Most microbes secrete compounds that are toxic to other microbes. So essentially, when we give antibiotics, we're affecting, especially broad spectrum antibiotics, we're affecting that ecology. And so if some of those microbes that are secreting compounds that are toxic, if those are wiped out by broad spectrum antibiotics, then other microbes that weren't affected by that broad spectrum antibiotic can flourish, right? Other things that microbes do kind of within their given ecology is that they compete for nutrients. And so basically they're kind of keeping each other in check, right? Because they're all competing for nutrients. Again, when we give antibiotics, especially broad spectrum antibiotics, some of those microbes that are all kind of competing for that food will be wiped out. And then once again, anybody that's not susceptible to that particular drug, has kind of free reign. They've got lots of food, they can keep growing, etc. So kind of in the end, what happens is the antibiotic use creates what is known as a selective pressure, favoring the growth of those microbes that weren't sensitive to that particular antibiotic. All of those toxins that would have been produced otherwise, those are no longer around to keep all the microbes in check. Now there's lots of food available. Because lots of those organisms have been killed off, and then kind of all in all, this creates these favorable conditions, and those microbes that are resistant can flourish. Like I said, this is worse with broad spectrum drugs because these kill off more types of organisms, leaving those resistant ones to grow. We really worry about, especially with broad spectrum antibiotics, we worry about superinfections. Superinfection is just a new infection that occurs when we're treating something else. And basically it's related to the fact that a broad spectrum drug is killing off normal flora. And some of those, by the way, all of that flora is kind of working together to keep each other in check. But then you kill off a lot of that normal flora, and then you've got some kind of bad guys left behind that can lead to new infections. Higher quantities of antibiotic use speed up overgrowth of some of the normal flora that are specifically resistant to antimicrobials. And then also we worry about the site of intense use. So think for a moment, where is one of the sites of intense use of antibiotics in our country? Hopefully you guys all said hospitals, right? Hospitals can be dangerous. There's resident organisms that can exist specifically in those environments, and they can be extremely drug resistant. And then, of course, they can easily be passed from patient to patient just because of close quarters, because of healthcare workers taking care of multiple patients, etc. So what can we do about resistance? Well, one thing I would urge all of you to do is go to the CDC website and take a look at the Get Smart for Healthcare campaign. It's all about preventing antimicrobial resistance. The link in the slide is a quick YouTube video. I think it's maybe 4 or 5 minutes. To take a look at it for sure. This website, just the general CDC website, it breaks down what patients can do, what healthcare providers can do, such as nurses and prescribers, pharmacists, and others, what healthcare facilities and payers should be doing. I think it kind of breaks things down into manageable pieces. I just want to go over a couple quick things, just for awareness for you guys. First of all, for healthcare providers. Well, obviously, healthcare providers should be prescribing antibiotics correctly, right? So that doesn't necessarily fall to me as a pharmacist or you, all of you as future nurses. It's really going to fall more to prescribers, which some of you I know will choose to go on to become prescribers. And so prescribing antibiotics correctly is really important. Reassessing the prescription, especially for broad spectrum agents after the first 48 hours based on tests and exams and so forth, is really important. Documenting the dose, duration, and indication for every antibiotic prescription is important. Staying aware of antibiotic resistance patterns in your facility and in your region, again, very important. Participating and leading in efforts within your hospital to improve prescribing practices, and even in other important practices like hand hygiene and other infection control measures with every patient. So that's really, of all of those that I just mentioned, that last one is absolutely going to fall to nurses in many, many cases. Following good hand hygiene and infection control, and even kind of being purveyors of that, making sure that others around you, including patients, understand infection control practices. In terms of education you might give to your patients, making sure they understand they need to take the antibiotic exactly as prescribed, don't skip any doses, and complete the course. Only taking antibiotics that are prescribed for them, not sharing or using leftover antibiotics from someone else. Not saving antibiotics, right? They're supposed to complete the course, and if there is anything left over, it's unusual for that to be appropriate, but if it is appropriate, then they would discard that. And then telling them, you don't want to just ask for antibiotics every time you feel sick. If you've got a viral infection, using antibiotics isn't going to do anything to shorten the duration of that viral infection, and in fact could only lead, down the line to creating a situation with resistance. The last thing I want to talk about is this concept of antimicrobial stewardship programs. So this really falls to the level of the healthcare facility, specifically hospitals. These programs, you guys may have heard of this on your clinicals when you hear the term, oh, that drug needs antibiotic approval. So basically what these systems are programs within the hospital that their goal is to slow the spread of microbial resistance through management of kind of who is allowed to get certain antibiotics, especially broad spectrum antibiotics. So we want to limit the spread of antimicrobial resistance, but also minimize harm from patients that results from inappropriate therapy or unneeded antibiotic use. These programs have been shown to improve costs, improve outcomes for patients, and also decrease the spread of antimicrobial resistance. I think right now we're kind of on the precipice of where these will move away from being kind of voluntary programs to be programs that are mandated by either local government or state government. But again, I mention them because when you guys start working as nurses, I'm positive that you're going to encounter these antimicrobial stewardship programs, and a prescriber will write an antibiotic like Zosyn or Mirapenem, which are both pretty broad spectrum drugs, and you'll call the pharmacy and say, "Hey, this order was placed an hour ago. Where's my drug?" And the pharmacy will say, "Well, we're still waiting for antibiotic approval. That's not a drug that we can just send because the doctor ordered it or the nurse practitioner ordered it." But rather, if they're going to order it, it has to be approved by the antibiotics approval specialists. So moving on from discussion of antimicrobial resistance, let's now talk about selection of antimicrobials. So there are several determinants of response with regards to the selection of antimicrobials. Obviously, the objective when antimicrobials are prescribed and administered is to produce a maximum effect, essentially, eliminating the organism. But at the same time, we want to minimize the harm to the host or the patient, right? So as we're thinking through the response that we see when antimicrobials are prescribed and administered, we can kind of group those determinants of what we might see based on the bacteria, or what we say bacterial. Those really, I guess it would be cleaner to say the microbial or the organism response, because not all of the organisms that we talk about are bacterial. But when you look at this in your textbook, the term they use is bacterial. Nevertheless, the drug, so the drug itself, so what is it about the drug that either causes a response, or maybe the response is less than what we might see, and then the host. So things like, where is the infection? Where's the site of that particular infection? So let's start by talking about the bacterial determinants. So the type of organism causing the particular infection is really the most important piece of information. Generally, we know, for a typical infection like pneumonia or a UTI, we know certain types of infections are more likely to cause those particular types of infections. And we know many drugs may work against those typical organisms. But in general, there's usually a specific drug that's kind of our first choice, that it's our preferred choice. That drug has better, in general, the drug would probably have better efficacy against that particular bug or organism. It may have lower toxicity to the host. In many cases, the drug has a more narrow spectrum, and remember, that is preferred, right? So when we're thinking through the infection and kind of what drugs usually cause that particular infection, first thing we want to know is there a drug of choice? And if so, is our patient able to take that drug of choice? And sometimes the answer is no. Maybe they're allergic to it. Maybe their infection is in a site where that particular drug can't get to. So maybe that particular bug, when it causes a lung infection, drug A is perfect for that. But if that particular infection causes meningitis, then that drug wouldn't be effective because the drug can't penetrate the blood-brain barrier. And so those kind of factors come in when we talk about the host. Adverse effects, so specific adverse effects may occur, given patient-specific variables. Could be issues with availability or cost. But bottom line is when we are thinking of a specific type of infection, or if we know the actual bug with certainty that's causing that infection, our first question is, what's the general drug of choice for that particular infection? So as we're trying to match the drug to the bug, if in many cases, we'll start with what we call empiric therapy. Empiric therapy means that we don't know with certainty what's causing the infection. We just have an idea of what it is. And we're going to start a drug of choice that's, related to that particular bug that we know is generally effective against that particular bug. But then once we've got identification of the causative agent, we would narrow therapy based on that. So again, it all comes back to the bacteria or the virus or the fungus, whatever type of organism it is we're treating. But we want to figure out, based on body fluids, like blood or sputum, maybe even a wound drainage, for example, we take that fluid and do lab testing on that fluid. There's a couple different types of tests that can be done. For those of you who have a microbiology background, you may have seen a Gram stain before. This is where you just look at that fluid under a microscope, and based on the morphology of that particular organism, we can make an educated guess as to what the organism is. In some cases, Gram stain is not conclusive, and then we may go on and actually do a culture. And in a culture, what we're doing is actually growing that organism on a media, and it could be all different kinds of media. But basically, we're trying to grow that organism, again, to positively identify what the organism is. Other types of processes like PCR, which is an amplification process, there's all different things that we do. But the basic ones, Gram stain and culture, is what I would want you guys to be familiar with. And again, the premise here is that you're taking some kind of bodily fluid and attempting to specifically identify the organisms from that fluid. So a couple key points with this, especially with regards to administration of medications, of antibiotics and antimicrobials. You want to obtain your sample before administering your first dose of antibiotics, if possible. And I want to be clear, there are some cases where that's just not possible and you can't delay therapy, but ideally we would get those samples collected before administering that first dose of antibiotics. And the idea is, even as soon as those antibiotics are administered, they could start suppressing growth of organisms. So it might make it less likely that you'll be able to actually grow anything from that culture if the patient's been exposed to antibiotics. Another key point, especially for folks that are drawing or obtaining these cultures, which in some cases that would be the nurse, is that you have to collect cultures carefully to prevent contamination, because the body is covered in all different kinds of organisms, and so having good practice with regards to collecting that culture is important. One last thing I want to talk about is colonization versus infection. And so with colonization versus infection, that, again, part of the diagnostic process, not anything that you guys, will have to do, but something you might want to be aware of. In colonization, all of us are colonized with all different types of bacteria. But it's important in deciding whether to treat, whether what we're finding is just a colonization that's not causing harm, or whether the patient actually has an infection with whatever that organism. All right, let's move on to the drug factors. So once we've got our cultures that actually grow something from them, then what we would do next is sensitivity testing. So you've got that organism on the medium, and now we're going to test it against multiple drugs. There's lots of ways this is done, and we don't need to get into the detail there. But essentially, we're looking to see what antimicrobials will treat that specific bug that was isolated from your patient. And a lot of times, the results of this are reported in terms of the minimum inhibitory concentration, or MIC. And really all that, again, without getting into too much detail, really all that's saying is, what's the minimum concentration of this drug that's needed to suppress growth or to stop growth, basically. So that's one drug factor that's important, right? Because not all drugs are going to be sensitive to that particular organism. Another drug factor is dosage. So the dosage of the drug could vary substantially based on the indication. And that has to do with a variety of different things, especially pharmacokinetic type things like can the drug get to the specific site of action? Do you need a lot of that drug for it to be able to get to that particular site of action? Or the specific type of infection itself. Uh, what is the seriousness of that infection, and then that dosage could vary based on that type of infection. And then bioavailability. So another drug factor that can definitely play into response. So with bioavailability, this can influence the route of administration, right? So if a drug is not bioavailable, then maybe we, can't give it by the oral route and it can only be given intravenously. Or maybe what it means is that the oral dose is much, much longer for that antimicrobial versus the intravenous dose. And that is definitely something that we see with antimicrobials, and that will influence the ultimate response. Finally, the host factors. Of all these, I think these are the ones that we focus in on the most. Some of the things that I went over with regards to the drug and the bacteria, I think a lot of that stuff you may already be familiar with, like the dose and bioavailability and so forth. But these host factors, these are important to key in on. First of all, the immune system. So the patient's immune system, are they immunocompromised or are they immunocompetent? Are their host defenses able to effectively eliminate infections? Some drugs aren't able to do that. They work with the immune system to do that. And so, like we said in the beginning, it's going to depend on, it could, be a decision point, whether or not the patient is immunocompromised or immunocompetent, which drug would be most appropriate for them. Infection site and source factors. I kind of talked about this a little bit when I talked about the drug, but let me go a little deeper into this. So with regards to the site, what we're really worried about here is, can the drug get to the site of infection? So can it penetrate into, wherever that infection is occurring? For example, blood-brain barrier. So you guys already know that drugs crossing the blood-brain barrier can be a problem. And so if a patient has meningitis, which is a very serious infection, it's complicated by the fact that many drugs can't cross the blood-brain barrier. So that host factor is certainly going to influence what drug you choose and what dose is used, and the potential response to therapy. Other sites where it's difficult to penetrate, purulent abscesses. These have very poor vascularity. We could do things like drain them surgically, and then in some cases it's a little easier for antibiotics to get in. But these tend to be difficult to treat. Endocarditis. Endocarditis essentially is difficult because it's kind of like an abscess almost. On the heart there's a vegetation. In many cases there's a thrombus that kind of covers that vegetation and conceals the organism, makes it difficult for the antibiotic to get in and treat it. So just a couple examples of infection site. And then source. So if a patient has a foreign material in their body, like a pacemaker, a valve, a shunt, phagocytes, which are part of the immune system, can attack these foreign materials, and then they become less able to destroy the microorganism. So these foreign materials can be a big issue. But bottom line, concentration needed at the target site is an important variable and something that we think very intently about, especially with serious infections in sites that are hard to get to. One of the things that is an issue with nearly every patient, or at least maybe not an issue, but at least something that we stop and think about. Every patient who's getting antimicrobials, we need to be thinking about their age and their organ function. So many of these drugs that we talk about, that we will talk about over the next few modules, are eliminated by the kidneys. And those that aren't eliminated by the kidneys are eliminated by the liver. And so adjustments for patients that have reduced organ function. And that is of particular concern depending on a patient's age, right? Any patient could have reduced organ function, but we worry most about that with the very young because their organs are still maturing, or the very old because their organ function is declining. So thinking about, do we need to adjust the dose based on our particular patient's organ function, especially kidney function or liver function. Pregnancy, of course, these drugs can have effects on the fetus. Lactation, they can have effects on the breastfeeding child. Genetic factors are of concern, especially with a lot of different antimicrobials. So the sulfonamide antibiotics, for example, if a patient has a genetic deficiency of glucose 6 phosphodiesterase, then this can cause hemolytic anemia with those drugs. So I will, when we come up to antimicrobials that have issues with regards to genetics, I'll bring those up. There are a handful that we're going to talk about that fall into that category. Obviously, adherence is a host factor, and it's very important. Not all patients are going to be adherent. Patients that do not complete their course of antibiotics are more likely for getting reinfected and getting reinfected with resistant organisms. So adherence is a big, important host factor. And then finally, allergy. We worry about allergy. Probably the single most important consideration with antibiotics is allergy, because there are several drug classes, several antimicrobial drug classes that cause allergy, such as the penicillins. So allergies are a really important one. Just to kind of deviate for a minute, if you do encounter a patient with allergy, documentation is of the utmost importance. Hopefully you guys kind of get why. If you don't, think for a minute. Why is it so important with allergies? Allergy documentation is always important, but why is it really important with regards to antimicrobials? Maybe stop the tape for a minute and kind of think about that. So hopefully you had a moment to think about that, or took a moment to think about that. So here's kind of my take on this. Well, number one, obviously allergy documentation is important, because if a patient does have a true allergy and it's an anaphylactic type allergy, which, in many cases the antibiotics and other antimicrobials can cause, it could be life-threatening if they receive that medication again, right? That's true for any drug. Kind of on the flip side of that is, if we say somebody's allergic and they're not really allergic, down the line, if they get infected with a resistant bug that's only susceptible to one particular drug class, but we think they're allergic to that drug class, there could be life-threatening delays in therapy before we figure that all out. So documenting allergies explicitly is really important for a variety of reasons. So we would want to include the drug, the description of the reaction, the severity, what the temporal relationship was between the exposure and the symptoms, when they occurred, had there been a prior exposure to that drug or similar agents in the past. These are some of the important things that we would want to include. Other things to consider: dosing. So with dosing, many of the antibiotics are based on weight, even for adult patients. So make a little note of that. Even for adult patients, I guess I shouldn't say many, but there's a handful of these drugs that we will dose them based on patient's weight. Obviously, all of them in kids are most likely going to be dosed on patient weight. Drug penetration, you might need a higher dose. So like I said, if the drug doesn't readily cross the blood-brain barrier, well, the typical doses we use probably aren't going to work. But in some cases, we're able to push the dose very high, and that drug can get into the blood-brain barrier and effectively eradicate the infection. Bioavailability, again, dosing could vary based on bioavailability. Some drugs we may not be able to use by a certain route because of the bioavailability. I'm going to talk about vancomycin quite a bit. I'm sure you guys have heard of vancomycin. It's prescribed pretty widely in hospitals. So bioavailability will influence the route, and with regards specifically to vancomycin, it could be the difference between life and death. That bioavailability difference could be the difference between life and death. And what I mean is, for vancomycin, and I used to get this phone call all the time when I was working as a pharmacist in the hospital. Somebody would call the pharmacy and say, I'm prescribing vancomycin. I want to know, can I prescribe it orally? And if as a pharmacist I said, oh yeah, sure, no problem, it's available orally, and then hung up the phone, I could have just contributed to somebody's death. And the reason why is because when you give vancomycin via the oral route, which by the way, it's available via the oral route, it's not absorbed. It stays in the GI tract. When it's prescribed for the oral route, it's to treat infections that are local within the GI tract. If you're trying to treat a blood infection or meningitis or any systemic infection, if you use vancomycin, it won't be absorbed and it will do nothing to treat that infection. So like I was saying, when I used to work as a pharmacist, I would have these residents that were trying to discharge patients. They're on IV vancomycin for a systemic infection, and then they would write for oral vancomycin for discharge, which is guaranteed to result in big problems. So bioavailability is an important consideration. Adherence, again, so in terms of dosing, we might not prescribe a certain drug because it has to be given 4 or 5 times a day. Well, if a drug's got to be given several times throughout the day, the chance of a patient being adherent are probably lower. So adherence certainly plays into whether or not drugs are prescribed, and it can even play into dosing as well. Sometimes it's possible to give 2 large doses over the course of a day instead of 3 or 4 smaller doses. So adherence and whether or not patients will take the medication as prescribed could certainly influence how they're prescribed and how the dosing is prescribed. Finally, organ function. This is, you have to know this. Star it, circle it, underline it. You've got to be familiar with organ function and its influence on dosing. Many antimicrobials, like I said, are renally eliminated. In many cases, the standard dose is not appropriate. By and large, antimicrobials are considered some of the safest drugs, especially penicillins and cephalosporins. These are pretty safe drugs. However, when they're not dosed appropriately because of declining organ function, they can produce serious adverse effects that in some cases can be life-threatening. So you have to be familiar with the fact that these drugs in many cases are renally eliminated. And when you're practicing as nurses, anytime you're giving antimicrobials, you want to check, is this dosed appropriately based on my patient's renal function? I would always err on the side of caution with that. And then lastly, duration of therapy. So this could be based on things such as the host defenses. Patients who are immunocompromised may need longer courses of treatment. Could be site of infection. So again, how difficult is it to get that drug to the site of infection? Those patients may need longer courses, or even the organism itself. Some organisms are very susceptible and may only need a few days of therapy, and some may need prolonged therapy, like fungal infections, which we'll talk about. Prolonged therapy for certain indications like osteomyelitis, endocarditis. That has a lot to do with getting the drugs to kind of penetrate into the site of action. But you've got to, with any prescription or any order that you're educating a patient on that's for an antimicrobial, you've got to talk to them about completing the entire prescribed course, even when they're feeling better, and explaining to them that if they don't, they're at risk for getting reinfected and getting reinfected with something worse. A couple kind of final thoughts. Combination therapy. We really don't do this a lot. Really, it's only done under certain conditions. It can be life-threatening, but like I said, not something we do routinely. When I say combination therapy, I mean 2 or more antimicrobials. And when we do this, it could be additive, meaning the 2 agents, kind of the sum of the response from the 2 agents is what we see. Could be synergistic, where we see a greater effect than the sum of using those 2 agents. For example, Bactrim is a drug we'll talk about. That drug is made up of 2 different components, and they inhibit sequential steps in the folate synthesis process. So we see even bigger results when we use those 2 together versus if we had just used them, each the kind of the effect of each of those alone. So that would be synergy. When do we do combination therapy? Right? So I think that should be one of your main questions, because I started this whole discussion off with, we don't do this a lot. So when is it appropriate? Well, could be for a very serious infection as initial therapy before we know what we're treating. Sometimes it's to treat mixed infections. So we might have a patient that's infected with multiple issues, multiple organisms. Maybe they've got a gram-positive organism and a gram-negative organism. And when I say gram-positive, gram-negative, that's just based on the kind of the morphology of the organism and kind of how they're classified. But we would need different drugs to target each of those infections. Could be to prevent resistance. And you guys might all be kind of going, huh? Well, that doesn't make sense because you told me when I'm using lots of drugs that I'm setting a scenario of creating resistance. And that's generally true. However, with certain types of infections like tuberculosis or HIV, we actually prevent resistance by using multiple drugs. And we'll talk about that when we talk about those individual infections. Decreased toxicity. And so kind of the way that works is you could potentially give lower doses of one or both drugs by using those drugs together. So that could, in theory, decrease toxicity. Or enhanced action. So one drug could do something that enhances the action of another drug. For example, penicillin weakens the cell wall. And when we use penicillins with aminoglycosides, the aminoglycosides are then able to get in and do a better job at killing off that organism by inhibiting its protein synthesis. So kind of enhancing the action of the other. So I want you guys to think for a moment, are there some drawbacks of using combination therapy? Why would we not want to do this? I just gave you some scenarios where it might be helpful, but what are some of the reasons why we generally don't do this? So pause the tape for a moment. So hopefully you said it could increase the risk of adverse effects or even allergies. There could be antagonism of effects. This is possible depending on the way that the different drugs work. That's certainly possible. You could cause super infections, right? Because if you're knocking out all different kinds of flora throughout the body, that puts the patient at risk for super infection. Certainly could select out drug-resistant bacteria. And it could also be costly. Those are just some of the reasons why we generally avoid using combination therapy. So the last concept I want to talk about before we conclude this lecture is the use of antimicrobials for prophylaxis. So up to this point, the context of my discussion was really around treatment of infections. But we do occasionally give antimicrobials to prevent an infection that hasn't occurred yet. Most of the time, this is not necessary. In fact, about 30 to 50% of all antimicrobial use in the US is for prophylaxis. And many experts in the field would say that most of that is just flat out not necessary. But with that said, there are certain scenarios where it is appropriate, certain types of surgery. In that scenario, we would give prophylaxis, like one dose of an antimicrobial 1 hour before the surgery, possibly during the surgery if it's a long surgery. But they would just get one dose for the most part, and that will help prevent certain types of infections that are related to surgery. Bacterial endocarditis. So with bacterial endocarditis, like I mentioned before, these patients could have a device or they could have just, because of the anatomy of their valves, they could have vegetations that are on those valves that are hard to treat. So really it's ideal to prevent those vegetations from even occurring. So with some procedures like dental procedures, in the past we routinely used antibiotic prophylaxis. Nowadays this is becoming much less common. There are newer guidelines that really kind of shy us away from that practice, but nevertheless there are still some scenarios where that might be appropriate. Neutropenia, so patients that have a high risk of infection, patients with cancer for example, we might use prophylaxis in those patients to prevent infection. And then other examples like a patient with a recurrent UTI, for example, or some sexually transmitted diseases. In some cases, it's appropriate to provide prophylaxis in those scenarios. Okay, so that's it. So like I said, that's the background of antimicrobial use. If you have questions, please post them to the discussion board, and thank you for listening.